Good afternoon, Mica from Spine Institute of Arizona. I'm here to talk to you about what's new in lateral. These are my relevant disclosures. The only one I want to bring up is just I do consult for prone lateral development for Gladys and for some of the feasibility with robotics for J&J. So, I've been charged today to talk about what's new in lateral-based surgery. And it's kind of an interesting question because it's kind of like asking what's new in AI. Really lateral surgery in itself is pretty new. And if you look at kind of, with following on Dr. Arnold's talk, if you look at the evolution, spine surgery starting in 650 AD with Paul Vagina, lateral surgery is really, really, really recent. Some of these surgeries, looking at the lateral spine started back in the later 1800s trying to treat Pott's disease with the extracavitary approach and costotransversectomy. And then as ALIF began to develop in the later 80s and 90s, we started looking towards more MIS and laparoscopic approaches. Again, there was an interest in how do you reach the lateral aspect of the spine, but this time, instead of a posterior approach, how to get to it from the front. But it wasn't until 1998 that Dr. Luis Pimenta, who's credited being one of the pioneers of lateral approach, really started to take his own journey on lateral spine surgery. And didn't really publish his technique until 2006. And so that's kind of when everyone started figuring out this new lateral approach. And then there were some nuanced ways of using the lateral procedure. And then in 2015, the concept of a single position lateral surgery was introduced. And then we started talking about navigated interbodies in 2017 and how we could use these technologies. And then prone lateral didn't really come onto the scene until 2020 with its description at that time. So when I looked at the, sort of my investigation into what's new in lateral in the past year, really 4 themes continue to surface. The first is driving adoption. The second is refining single position lateral surgery. The third is improving upon and understanding better nerve localization and monitoring. And the fourth is integrating enabling technologies. And adoption is an interesting topic because when I was learning about lateral surgery in the 2010s, it was kind of cited that 20% of surgeons adopted lateral surgery. And so trying to figure out where we are now, it's supposed that about 20 to 30% of lateral surgery has been adopted by surgeons in the US. But is that really the number? I mean, if you look at it, that's based on implant sales. And so when you look at lateral surgery, there's about a 10 to 15% population of surgeons who comprise between 60 and 80% of all lateral implant sales. And so although we see an increase in usage of lateral implants, about 10 to 15% year over year. The question is that because there are new surgeons learning lateral and doing more lateral surgery, or is it lateral surgeons are doing more lateral surgery? And I don't know if there's a good way to get a beat on that. There are about 250 studies published in the past year looking at lumbar lateral interbody fusion. And a good lot of them looked at how does lateral stack up against TLIF. As the importance of alignment has sort of bled in from deformity surgery into day-to-day degenerative surgery, there has been a bigger focus on segmental alignment, lumbar lordosis, and lumbopelvic match. And these 2 studies that I wanted to sort of highlight here look at that. The first of which demonstrates that we are more likely to achieve segmental alignment goals in lateral than we are with TLIF. The second study showing that again, you are more likely to induce more lordosis with lateral-based procedure than you are with a TLIF-based procedure. This third study looks at the same radiographic outcomes, but also extrapolates some patient-reported outcome measures. And in their study, they found that lateral-based surgery was better at driving segmental lordosis, lumbar lordosis, restoring disc height, restoring foraminal stenosis, but also restoring lumbopelvic match. But then when they looked at their 2-year patient-reported outcomes, they found that they were exactly the same. And then This last study highlights something I think that prevents a lot of people from embracing lateral surgery. I mean, we all love the L3-4 chip shot, but most of the pathology lives at L4-5, and there are a number of nuances at L4-5 that limit access from the lateral approach, be it your crest, the plexus, the nerves, and some vascular structures. So there's been concern about safety, and a lot of development in lateral revolves around safety, because ultimately that's what we want. We want good outcomes in a safe manner. This study looks at basically 500 plus patients, and they use specific criteria on who they indicate for lateral procedures at the L4-5 level, looking at things like the height of the crest, things like where is the fat streak as a surrogate for nerve and plexus location, looking at where are the vessels. And if you isolate the patients that really do satisfy all their criteria, if you look at 1 year long-term outcomes in this study, they had no patients with permanent femoral nerve injury. So they're demonstrating that if you're mindful about the way you approach lateral, even at the L4-5 level, it can be safe and effective. We talk about, the lateral is not just lateral in the lateral decubitus position. So, single position lateral surgery got a lot of attention because it eliminated the flip. And so that in the middle 2010s became quite popularized. And then more recently, there's been this foray into the prone position in lateral surgery. But there are some limitations that this creates for the surgeon. Specifically, when you're placing your retractor in the lateral position, it's low, so you have to raise the bed higher. Some of the new positioners help with increasing that height. They help with instituting some rotation into the patient inherently, which can help you look down the retractor. Also, in the lateral position, you're not working in the direction of the table, you're working parallel to the floor. So a big problem you have is pistoning. And a lot of these positioners have been focused on trying to prevent pistoning by putting contralateral posts, strapping the patient to the table to avoid that pistoning. And additionally, with the pistoning comes the problem of your retractor undocking from the disc space. And so table-mounted retractor arms institute a good force vector towards the disc space to, again, try to avoid that problem. And so here comes the talk about prone lateral versus lateral decubitus lateral surgery. So single position prone lateral versus single position lateral decubitus surgery. What's the need for that? And the idea is being the single position surgery tries to eliminate the time you need to flip. And this study I found interesting, I think highlights that. They basically saw between their patients that did in the lateral decubitus position compared to the patients that did in the prone position, they eliminated about 45 minutes in their overall surgical time, which is typically your flip time, depending on how good your team is in getting your patient moved. And then the second paper I wanted to highlight, another interesting paper in this space, looked at what happens to your intra-abdominal contents in your different positions. So one of the theoretical advantages of putting a patient prone is that their belly hangs freely, and the thought being that all of their intra-abdominal organs would follow. This study took patients, live patients, took them in an MRI scanner and positioned them in different positions and looked at what happens to their intra-abdominal contents, lateral versus prone. And what they found is that in the lateral position, the intra-abdominal contents tend to shift away from your working corridor more than they do in the prone position. And furthermore, they also found that the working distance between the skin and the spine was longer when the patient was held in the prone position. The next sort of overall arching topic of improvement revolves around intraoperative neuromonitoring. Neuromonitoring and safety go hand in hand with lateral surgery with multimodal monitoring modalities like EMG, SSEP, and transcranial motor evoked potentials. Those have been elaborated on in the past few years. There's also been an introduction in ultrasound mapping of the plexus for safety. But more recently, in this past year, there's been a few studies looking at both trans-abdominal motor evoked potentials and trans-abdominal motor action potentials. They're not the same thing. They have two different names. The trans-abdominal motor evoked potentials in this study, they basically looked at this compared to transcranial motor evoked potentials. And what they found is that at baseline, these patients had more reliable baselines. Their transcranial, as they compared, trans-abdominal as they compared to transcranial are more sensitive and specific. They found that they had less false positives and no false negatives. So a good modality. This space is being more elaborated on recently. This is a Bill Smith's study looking at trans-abdominal motor action potentials, and this was really just a feasibility study. But the part that remains a little nebulous about TMAP is, so what are your alert criteria? How do you establish the proper timings to do, because this is not a continuous monitoring. This is something you have to intentionally monitor. And so actually one of our speakers today, Ash Patel's group, is going to be putting out a paper looking at sort of when those timing processes are and what those threshold criteria could possibly be. And then a paper that was published that really created a lot of controversy, particularly in the social media space, was this paper looking at the dogmatic 20-minute rule in lateral surgery. And the question, my growing up in lateral surgery was, once you dock your retractor, you have a finite amount of time to do a good job, get the job done, and get out of there. And the idea being, you know where the nerve is, but you don't know how the nerve is acting. And the thought process is, well, maybe this is not a dogmatic gospel that we need to stick to. Perhaps we need to figure out where the nerve is, and we need to figure out how the nerve is tolerating us being there. And so that sort of, again, illustrates the importance of actually TMAP and TCMEPs. And then lastly, enabling technologies. They've been conventional in a lot of the surgery we've done with navigation, and we've used navigated screws to help us with lateral decubitus surgery. But now the attention's been turned to how do we navigate the inner body space, and the difficulty that poses that when you start manipulating the inner body space, you change the relative anatomy. And lastly, just augmented reality with trying to reduce cognitive load. So what's new? Driving adoption, defining single position lateral surgery, improving safety and nerve localization monitoring, and integrating enabling technologies. Thanks.